So thanks very much for joining us today for the Canadian HIV Hepatitis C Management and Treatment Guidelines session. We have been working on this for well over a year now, and we're now into the phase where we are soliciting feedback from everybody, all the stakeholders who have an interest in HIV hepatitis C care. The last guidelines were published well over a decade ago, and so clearly there's been significant advances in our understanding of HIV hep C co-infection. And I don't mean just clinical management is advanced, but our understanding of the epidemiology, the social sciences, the basic sciences have progressed tremendously. So, so it was clearly time to create a new document. So what I'm going to do is provide a little bit of background about how we got to this point today, introduce the working group, and then present the recommendations to give the audience an opportunity to provide feedback. Okay? This is not intended to be a HIV hepatitis C 101 session. Okay? This is an opportunity to present the recommendations and get a sense as to whether most people agree with them, most people disagree with them, or whether there's some way that we can tweak them. Okay? We encourage audience participation. Keep in mind that we do have quite a bit of material to cover. There's currently 37 recommendations in the document, so I at times may have to ask people to shorten their question. I'll ask the panel to keep their responses succinct, and I'll also ask the people on the panel as you're presenting to mind the time. Okay. You will notice that on your table there are cards. Okay. So if you are shy and don't want to get up to ask your question, you can write down your questions, your comments, your feedback on this. And you can either leave it on the table where it'll be picked up at the end of the session, or you can drop it off at the CTN booth, which is just outside. Okay. As well, so there's microphones that'll be floating around the room. So if you have a question, just put up your hand, and Kevin and Melanie will get to you. Okay. Since mid-March, we've been sending out emails to anybody participating at the CAHR meeting. CTN info at hivnet.ubc.ca. And if you indicate an interest in reviewing the document in great detail, then that's the way to do it. Okay? Okay. So, in October 2011, at one of our CTN co-infection core groups, we decided that it was time to develop a working group to work on a consensus. We had a meeting in February of 2012 and divided up the writing tasks. Okay, and for the last year or so, we've been working on the document. Okay, in March we began circulating a preliminary draft, and April, right now, we are presenting the draft. Okay, we're hoping to have all the feedback. We hope to have back for April 26th. And we're hoping by May to be able to submit this to the Canadian Journal of Infectious Diseases and Medical Microbiology. And we're already in discussions with them, and they seem very eager to pursue publication. Okay. We also are working with multiple stakeholders and knowledge translation organizations to make sure that this isn't just a document, but that this gets to all people who are interested. Okay. The names on the list here are the people on the working group. Okay. I'm Curtis Cooper from the U of Ottawa. This is Pierre Giguère. He's a pharmacist from the Ottawa Hospital and one of my friends and colleagues. Mark Hall, we all know Mark Hall. Mark gets special credit. He's just put in countless hours working and writing on this document, trying to hound people to get the materials. So Mark has clearly earned his place on this document. Okay. Steve Shafran from the University of Alberta has had a very important role in this. And Alice Singh from U of Toronto is another pharmacist and has been very valuable. Unfortunately, Marina Klein wasn't available today. She has had a very important role in steering and directing this over the last year and a half. Okay. There's several organizations and individuals that deserve mention. This session right now is supported by a CAHR dissemination events grant, so we thank them very much for their contribution and their willingness to support this endeavor. Several companies, including Merck and Gilead, have stepped up to the plate and provided some support. I would want to emphasize that they were unrestricted grants and have not, at least in our minds, influenced the content of the guidelines. If you think otherwise, please let us know. Okay. From the CIHR, CTN, they've been very helpful, especially special mentions to Kevin Pendergraft for helping with this, getting feedback from key stakeholders. Jim and Dave Cox for their support of this initiative from the CTN, and Dave Mackey, who is one of the CTN co-infection core research assistants who's helped with writing the document. Okay. From CAHR, which has also been behind this initiative, Andrew Matajic and Aaron Love. Okay. Which brings us to the recommendations. One other comment. Okay. I do apologize that I don't have French slides for our French first speaking audience. There's nothing I can do about that today. This document is currently an English document, but Mark and I have had detailed discussions about this, and our ultimate goal is to have this full document in a French form as well. So keep an eye out for that. Okay. So, for this document, we used a classification system that's identical to the one that was used for the Hepatitis B consensus guidelines and the Hepatitis C consensus guidelines that were published last year in the Canadian Journal of Gastroenterology. Okay? There is a class system and a grading system to help to identify how good the data, how good the evidence is to support our recommendations. Class 1 is where there is very good evidence and general agreement that there's a benefit. 2, well, not quite as good. And 3, where the conditions, where there's evidence and general agreement that it's not, that whatever diagnostic evaluation procedure or treatment is not useful. Okay? I actually, when I went through the document today, I actually found that I forgot the not in class 3. So if you happen to read the document, you read this 1,000 times and you still run across those things. Okay. Grade of evidence. Level A is data derived from multiple randomized clinical trials or meta-analysis. B is data derived from a single RCT or non-randomized study. And C is because a bunch of people with big heads thought it was a good idea. Okay. So I am now going to launch into the recommendations, and I'll do the first section, which is the epidemiology of HIV and hepatitis C. Okay. So we start off the document with some background about the HIV and hepatitis C document, make the statement that hepatitis C is a more severe disease in those with HIV. In the next paragraph, we describe the epidemiology in Canada, and we talk about the populations that are at great risk for this, including women, youth, Aboriginal injection drug use. We also, in the next paragraph, cover incarcerated populations and their increased risk for hepatitis C exposure, as well as HIV. Okay. There is a section, sexual transmission of hepatitis C, where we cover the current epidemic of acute hepatitis C infection in MSM. Okay. Which then brings us to the first recommendation, which is all HIV positive persons should undergo screening for hepatitis C antibodies when first evaluated. Screening should be repeated periodically, particularly for high-risk individuals found to be initially negative, such as active injection drug users, aboriginals, and persons who have been incarcerated. And we also state that HIV MSM should undergo screening for hepatitis C antibodies annually in combination with liver enzymes every 6 months if sexually active, and hepatitis C antibody should be performed whenever there's an unexplained elevation in liver enzymes. Okay. Recommendation number 2 is identification of hepatitis C co-infection and HIV provides opportunities for prevention of transmission, risk reduction, counseling, and linkage to care and harm reduction services. That seems like one of those obvious statements. Okay. After this, we spend more time talking about the risks of exposure. We talk then about the distribution of hepatitis C genotypes in Canada. And then there's a section about the effect of HIV on the natural history of hepatitis C, followed by a brief section on health economic impact of hepatitis C, which then brings us to Mark Hall's section. But before we do that, any comments on the actual recommendations themselves? Any tweaking that you think that is necessary? Any comments from the panel? And for obvious recommendations, we don't need to spend a lot of time because I'm sure we'll run across things that may be a bit more contentious. So I'll ask Mark to come and describe the section dealing with managing HIV in the setting of co-infection. And remember, you do have these cards to provide your feedback. Do you want this here?
I'll leave it there, yeah.
Okay.
So before we move on to that, Curtis, I think we just mentioned the acute MSM or acute hepatitis C and MSM was one that the panel spent quite a bit of time at least reviewing the data that's out there. Most of it's been generated, as you know, from Europe or Australia, but there is some growing Canadian data that's the case. And there are some mathematical model studies looking at how frequently people should be tested. And I think that's an area that might evolve over time. So I think it's one of considerable interest. For the HIV section, within the text of the document, we basically looked at 2 areas. First of all, managing HIV, and then basic workup for co-infected patients. For the HIV recommendations, we broke it into 4 sections. So the effect of the natural history. So we know that HIV accelerates the natural history of hepatitis C, and that's covered in the early section that Curtis has gone through. And as the basis now for the section that we look at, effects of modifying HIV impacting on that natural history. So we have a section, if I can move forward, looking at initiation of antiretrovirals, both in terms of type of antiretroviral to be used, and then the timing of antiretroviral therapy in the natural history of co-infection, trying to recognize the fact that there's growing data, and I'll show you some of the slides that we looked at in terms of background information that might affect progression of natural history. In other words, by initiating antiretroviral therapy earlier in the disease course, we might be able to slow progression of liver disease, and this might be a factor in terms of treatment initiation for co-infected patients. So when we reviewed the data, we've come up with our first recommendation in terms of what agents to choose, and the panel felt that for first and second line antiretroviral regimens that would be used under present guidelines, and these are all have data to show they're well tolerated and effective in co-infected patients. Within the text of the document, it didn't make it into a recommendation section. There are a few caveats in terms of patients with cirrhosis or more advanced liver disease, and we have a few references where certain agents that are not commonly used, such as topranavir, may be used with caution in cirrhotic patients. And there's also some data that some other agents may be slightly more well tolerated. But overall, we felt all current first and second line agents should be used as per current guidelines with no differentiation between being HIV monoinfected or co-infected. The second area, which is quite the bulk of the text in this section, is looking at the evidence behind the effect of HIV on acceleration of the natural history of hepatitis C. and we felt that there's enough data to suggest that early initiation of antiretroviral therapy may slow progression of liver disease. In all current major guidelines, so the British guidelines, the European guidelines, the International AIDS Society USA panel, and the DHHS guidelines from the USA, there are various considerations and actually different breakpoints that are used for when to consider initiating antiretroviral therapy in co-infected patients. And at the end of the day, the panel or our recommendations are very similar to the European recommendations, which is clearly there's very clear benefit from an HIV perspective that early initiation of antiretroviral therapy, CD4 is less than 500, is helpful for their HIV and should be considered in individuals who first come to care with CD4 is less than 500. The question about initiation at higher CD4s is one where there's less data, but still some data to guide us. And in the international guidelines and the US guidelines, obviously co-infection is a consideration for routine recommendation for antiretroviral therapy in those individuals with high CD4s, where the initiation of antiretroviral therapy is thought to slow down the progression of their liver disease, and this is something that we've offered as well. So in patients who cannot access hepatitis C at that stage, early initiation of antiretroviral therapy may help to slow the natural history or slow the progression of their liver disease. So our fifth recommendation overall is in individuals with high CD4s, if you can't access hepatitis C therapy, at minimum antiretroviral therapy should be considered an option. And our final recommendation in this setting is in individuals with high CD4s, so over 500, our preference would be, if at all possible, that hepatitis C therapy should be considered first in those patients or in those individuals as a means to decrease the risk of future antiretroviral hepatotoxicity when they finally do have to initiate antiretroviral therapy. So this is based on slightly less high quality data, but there's enough data to, again, suggest that individuals who have a choice, so their CD4s are above 500, if at all possible, consider hepatitis C therapy first, and then sequence on to consideration of antiretroviral therapy thereafter. As we know, their tolerability will improve. So as part of that, I'm just going to show you some of the background data that's gone into that discussion. There are 11 cohort studies and 4 major studies that have looked at the impact of antiretroviral therapy on slowing the natural history of liver disease. This is one of the seminal papers from Germany and the Berlin cohort published in the Lancet in 2003. And you can see in the survival curve that untreated individuals were dying at quite substantially higher rates of liver disease complications than people who are ultimately able to access dual or combination antiretrovirals. And then finally in the top curve, which really showed a very nice reduction in mortality, true combination antiretroviral therapy or highly active antiretroviral therapy substantially slows the progression of end-stage liver disease in co-infected patients. So that's one of the major studies that's shown this very nicely. There's another study, again, similarly looking at actually hepatitis B and hepatitis C co-infected. But if we look at the hepatitis C aspect of it, as people were able to access, again, dual and finally triple therapy, there was, again, substantial reduction in liver-related mortality in that co-infected patient population. So very clearly, we can see that initiation of antiretroviral therapy removes some of the negative impact of being co-infected, and therefore, potentially, the sooner we do this, the better it is to access therapies, so at higher CD4s to slow this curve. On the other hand, and this hasn't been published yet, but was shown at IAS in Washington last year, we can't forget about the need to consider antiretroviral therapy as being part of the continuum of care. And hepatitis C therapy still clearly is indicated in co-infected patients. So in this Veteran Affairs data set, where they have a very vast cohort of veterans, they were able to look at outcomes of individuals who are accessing antiretroviral therapy and actually fully suppressed on their antiretroviral therapy and compare them to hepatitis C mono-infected patient populations. And you can see, despite accessing antiretroviral therapy in a successful manner, in their cohort, co-infected patients still had higher incidence of hepatic decompensation despite accessing antiretroviral therapy. So clearly this goes into our recommendation that hepatitis C therapy should be considered in all individuals and, if possible, as I'll show you with this slide, prior to their HIV therapy, if their CD4s would allow you to do so. In this paper from a group in Spain, what they looked at was outcomes of antiretroviral therapy initiation in patients who had previously had hepatitis C therapy. So they had 132 overall individuals who had been treated for their hepatitis C, and they looked at what would happen when those individuals started antiretroviral therapy. And you can see in this curve quite nicely that those who successfully had cleared their hepatitis C had a much lower annual incidence of antiretroviral-related intolerance or transaminitis compared to those who did not achieve an SVR. So again, some supporting data to suggest that if you can sequence people through hep C therapies first, you might improve their ultimate tolerability. So before we move on to the next section, I think I'll pause here and see if anybody had any particular comments or questions for the panel at this point. Otherwise, you can wave some cards and somebody will collect them and we'll look at the suggestions later. Because otherwise, we're going to be having a very short lunch session. I can't actually see beyond the lights, so somebody has to just like really wave a hand. I think there's somebody who's going to get very fit running a microphone around the room. So if he goes down, somebody else is going to have to take over.
I hope not. My question is to the first presenter. I was wondering that you mentioned priority people and you mentioned Aboriginal, MSM, women, but you did not mention African, Caribbean, and Black people. Is it that there's no co-infection in this priority?
That's a good point. It's not a purposeful exclusion, and we will address that.
I don't know if Curtis mentioned, we also have a section on incarcerated individuals, so we'll definitely go through the evidence in terms of those risk groups. It might actually be in there, and we just don't recall off the top of our heads.
I figured if I went line by line, we'd be here till about 1 in the morning. So obviously, we've had to really blow over a lot of content very quickly. Sharon has a question.
Just a couple of comments. One, I assume this is adult.
Microphone.
Yes. Sharon's question was whether this guideline was intended for pediatric populations, and the answer would be no. This is specifically an adult guideline.
So I think you need that in a title somewhere.
Yes.
Also, you know, you're right, many of these guidelines have suggested earlier initiation of antiretroviral therapy, but in your big document, there's not sort of a comment about making sure that they're prepared and adherence and all those issues, because this is a population in which that may be a challenge. Yes, definitely so. The European guidelines actually, as their preamble, have a 2-page section to look at readiness for antiretrovirals. We thought it might be a little bit too far afield to incorporate all those similar suggestions here, but I think you're right. We need to have a clear statement to suggest that initiation of antiretroviral therapy is not an easy decision, and it's a commitment in terms of lifetime therapy under our current practices, and people definitely would have to be prepared and not take this on lightly for sure. The other final section that we had in terms of HIV and antiretroviral therapy management relates to when you do decide to treat co-infected patients who are on antiretrovirals. There are concerns in terms of which antiretrovirals are most appropriate for use, both with pegylated interferon and ribavirin, and subsequently with our new protease inhibitors, hep C protease inhibitors, in terms of drug-drug interactions. And that's going to be covered in a full section of its own in terms of recommendations and monitoring and management of drug-drug interactions. So if you have questions about that, save it for a little bit later in this panel discussion, because that will be covered in a lot of depth. The next section...
Mark, can I ask you a quick question?
Oh, hi, Dara.
Hi. So this is a question both to you, Mark, and I guess to Curtis, because it was in the section that Curtis presented, but that you commented on, the issue of frequency of hep C testing, or specifically screening, in sexually active HIV-positive MSM. Yeah. So you alluded to some modeling data. I guess my question is whether you want to, or could you comment on something about frequency of sexual activity or a number of partners in the actual recommendation? Because I think as Curtis read it, it says something like any HIV-positive MSM who is sexually active, which it encompasses a huge swath of people,
Yes.
and I just wonder about the frequency of Q6 monthly testing in someone who has only, even one partner, one monogamous partner would even fall under that.
Yeah, so that's a good point, and I think we can maybe change the wording of that slightly, that section slightly differently in terms of that particular recommendation. There's two things, really. Are you going to be at risk in terms of potential exposure? So if you're in a monogamous relationship, potentially, hopefully, that would be not likely to be the case. And in you're probably referring to the CID paper that came out last summer that looked at modeling of testing frequency. And basically, in their analysis, both in terms of utility and in terms of cost effectiveness, it really was based on your community prevalence and your risk of encounters, basically. So I think we can look at that to say that, in people who are having more than one sexual partner, or change the wording slightly to recognize that not everybody is at the same risk, just purely being HIV positive MSM. So I think we can change that wording slightly to reflect that in a bit more detail. Okay, I don't see anybody else waving any cards at this point, but we'll have a lot of panel time at the end for things to percolate through, and if you're sort of ruminating about a thought, we can come to it a bit later on. So the next section is actually very straightforward, and I don't anticipate that we'll have a lot of comments. A lot of the recommendations that we go through at this point are very similar, in fact, somewhat identical in some circumstances to recommendations made for hepatitis C monoinfection, because the question really in this section addresses baseline evaluation. And we really didn't think that there was that much different that would distinguish a co-infected patient for their evaluation compared to a mono-infected patient in the overall scheme of things. So the recommendations here, I think, are fairly straightforward and probably don't require too much discussion, I would hope. So obviously this has already been touched on by Curtis, but we revisit this issue in a little bit more detail to be sure that everybody's on the same page in terms of what we mean. So after screening positive for hepatitis C antibody, people should be evaluated with hepatitis C RNA PCR. I think this depends a little bit in terms of what province you're in. In British Columbia, for instance, all our assays now are quantitative, but in some provinces, I think there might still be a qualitative assay that's being performed. And obviously, ultimately, to determine type of therapy, those who are found to be hepatitis C RNA positive should undergo hepatitis C genotyping, as this will have a major influence in terms of your approach to therapy. So I think fairly straightforward recommendations. I don't think there's anything too controversial. The next question, again, I think is one that might warrant some discussion. Certainly we had some discussion about frequency, again, of recommendations for testing. And there are different documents depending on which province you live in for the next recommendation, which is recommendation 9. So here we look at people who are tested at baseline, found to be hepatitis C antibody positive, and found to be hepatitis C RNA negative. In other words, suggesting that they might have spontaneously cleared their hepatitis C prior to considering them for therapy. And we know in some data, and I think we're working on this in the CTN222 cohort, that one negative test doesn't mean that you have fully cleared your virus. There are some variability in terms of the tests and viral replication. And so we think patients who have tested negative at baseline should have repeat testing to confirm spontaneous clearance over a more extended period of time. So you don't falsely tell somebody that they're cleared spontaneously based on just one test value. In British Columbia, the Ministry of Health guidelines recommend that people should go under repeat testing over a 2-year period, so I think 4 tests over a 2-year period. And we didn't come up with a specific recommendation in terms of how frequently tests should be repeated. And so I think that's one that we would certainly welcome some feedback on if people had very strong feelings in that regard. I don't know in Alberta, Stephen, if there are specific recommendations for that. No. The other aspect, again, is for additional co-infections or additional potential hepatic infections. And so we, again, make a fairly standard recommendation, which should be made for HIV mono-infected individuals anyway, that patients should be screened and, if non-immune, offered vaccination for hepatitis A and B. The other question here, which I'll take the liberty of saying didn't make it into the guidelines, but I think we, again, would welcome some feedback, is in Vancouver and in British Columbia, The province recommends actually additional vaccinations for pneumococcus and influenza. We didn't include that in this document at this time, but if people had strong feelings about it, I think, again, we would welcome some feedback. They thought there were some additional vaccinations that we should consider offering. I think, obviously, for HIV, you should be offered those anyway. And so we didn't feel that for co-infected patients, there was a specific need to call that out. The other evaluations are, again, very similar to what's suggested in mono-infected patients. And we have a table with the appropriate tests that should be performed. Is that all individuals at baseline should be evaluated for other conditions which might result in chronic liver disease. And by this we mean other comorbidities such as hemochromatosis or autoimmune hepatitis or other conditions that might ultimately influence the sequencing of when you would consider hepatitis C therapy and actually your comfort for doing so. And again, another fairly straightforward recommendation, given its effects on progression of liver disease, all patients should be counseled regarding alcohol, hopefully abstinence, but certainly reduction to, again, slow the natural history of their liver disease. The next section is one which in some provinces might be a bit more of a challenge. Which is the panel felt very strongly that there's enough data to suggest that ALT alone is not a criteria indication for accessing hepatitis C therapies in co-infected patients. There's enough data to suggest that in co-infected patients, even with a normal ALT, other testing modalities might uncover a significant degree of fibrosis in a small proportion of people, depending which study we referenced. Between 10 to 20% of people who are co-infected may progress to significant fibrosis despite normal ALT values, and therefore we feel that ALT alone should not be the basis by which practitioners restrict or determine access to hepatitis C therapy. A baseline ultrasound might help you assess for signs of underlying liver disease, and we think this should be considered at baseline in all co-infected patients. And the next question really comes down to is, how else are you going to move ahead to assess them for fibrosis? And we're fortunate in Canada in some tertiary care centers, and hopefully eventually this is going to expand to other less tertiary care centers, that other non-invasive markers for fibrosis assessment should be considered. So we have the FibroScan. So this is a machine that's similar to an ultrasound that performs transient elastography and tells us about liver stiffness and allows you to grade or stage somebody's liver disease in terms of an equivalent to a MEDAVIR scoring system. So a MEDAVIR is what is used for liver biopsies, and the FibroScan has been shown to be very, very equivalent in terms of an assessment to biopsies. And we think if this is available, this should be strongly considered as part of your baseline assessment. The hepatitis C cohorts, initially using data from Curtis's and Marina's studies, have also validated laboratory testing that could help you in this sense. So there's an APRI ratio, so the ratio between your AST platelets can be used to score somebody in terms of their risk for fibrosis. So if you have a high APRI score, this does have quite good correlation with at least F2 or higher fibrosis. And so if you don't have access to a FibroScan, you should be considering some of these other modalities to help you assess their degree of liver disease. In some geographic locations, you have access to a fibro test, which I think actually is a patented test that you have to pay for if you can't do the separate components, but it should be considered. Because we think there's enough data to suggest, as I mentioned already, that people with co-infection may have more fibrosis than the ALTs would let on. Whoops, sorry, I'll go back. I should just mention before I do so that liver biopsy up until now has been the gold standard, but again is limited in terms of patient acceptability as an intervention, tolerability because there are obviously significant potential risks for an invasive procedure, and there may be some sampling bias in the testing structure itself. So we don't feel a liver biopsy is ultimately or absolutely required, but it could be one of the other strategies that you could use if you don't have access to non-invasive modalities, and in some patients may actually be necessary if you're trying to sort out between certain liver conditions. So the next recommendations really are, again, a monitoring of patients with more advanced liver disease. And here we follow fairly standard international recommendations that patients with underlying cirrhosis should be screened for hepatocellular carcinoma. So at least ultrasounds every 6 months. There is some consideration for alpha-fetoprotein monitoring. It's dropped down in terms of the evidence behind it, and we didn't include it in this particular document. But if you had access to it and felt strongly about it, I don't think it would hurt. And ultimately, hepatitis C is a collaboration, a multidisciplinary collaboration, and so individuals with cirrhosis should probably be seen by a hepatologist or gastroenterologist for consideration of esophageal varices screening and potentially follow-up. So depending where they fall, having no varices, grade 1 varices or higher, their follow-up would differ between frequency of repeat testing and need for other interventions such as beta blockade to help reduce portal hypertension. So we do strongly recommend that patients with cirrhosis should be seen by a gastroenterologist or hepatologist in this regard. So I think that is the end of that section, and I'll pause here again and open it up for any questions or comments. I think those, again, are fairly straightforward recommendations based on mono-infected guidelines in Canada and in US. So if anybody had any particular suggestions, I see Daryl standing up. Daryl.
Hey, this looks great. This might be a little bit out there, but did you guys give any consideration to hepatitis E? So there's emerging data about acute and chronic hepatitis E and HIV and in immunocompromised populations, mostly in transplant, but there's a little bit in HIV. Yeah. But there's also a lot of problems with the serologic assays and availability of the assays. So I wonder whether you consider that and might even put a comment in about the lack of data or appropriate.
There is data in advanced HIV that you can have a chronic hepatitis E infection, which is not normally thought to be the case. It's thought to be just similar to hepatitis A. Marina and I are actually working on a seroprevalence proposal with the people in Winnipeg, so hopefully we might actually generate some Canadian data in that regard. But we didn't specifically put in screening for hepatitis E in this situation. I think in the situations where that has been shown to be more effective are in people who have unexplained liver disease or unexplained transaminitis with advanced HIV. We are starting to screen those individuals in our clinic. We haven't found any. I've heard from colleagues in Montreal that they've had 1 or 2 cases of chronic hepatitis E. So we could go back, but I think we might leave it as a fairly in the text comment, but not as a recommendation per se.
So we're keeping time in mind. Let's try to keep the questions short and the responses short as well.
Mark, did you consider a recommendation for rescreening people who either cleared spontaneously or cleared by therapy? Because people do get it again.
Yes, I think that's one of the questions where we're going to have to put into that screening component for those who are negative. We've had in our clinic at least 3 individuals who were reinfected actually through sexual acquisition following successful HCV therapies. And this has been well described now in the Amsterdam cohorts as well. And so I think we might add that in as part of the sexual screening comment that Daryl had, because I think that's a very important thing to recognize, that you're not immune to hepatitis C even if you have been successfully treated or if you have spontaneously cleared. Brian Conway's data has suggested that the risk of reinfection is actually quite low in people in his cohort, but we've seen some other studies that were presented in Glasgow from an incarcerated population that suggest there might be quite a bit of ongoing reinfection and clearance. So I think it's well worth a comment. I agree with that. So, hi.
In regards to hepatitis C antibody negative patients, you mentioned in the text in the severely immunocompromised patients, but you don't mention a CD4 cell cutoff for those patients, number one. Secondly, I'm wondering if you should make a recommendation to do an initial hep C RNA in these antibody negative patients, because even in my relatively small population, I've had a number of patients who have been antibody negative but RNA positive.
Yes, I agree with you. I think in terms of an actual CD4 count for advanced HIV, we left it fairly open to have your own interpretation of what you think you might do that in. I think in the data, certainly less than 200, you should be considering an RNA test, probably. The way that we phrased it in our local sort of education outreach has been, if you have somebody who's had potential risk for hep C, has abnormal liver enzymes, an RNA might be warranted. Depending on in your location, the lab may not pay for an RNA unless you're antibody positive without special approval, but I think we can add that back in. It's in the text for sure, but we could consider adding it back into the recommendation section. Thank you for that comment. So I'm going to pass it on to Stephen just to keep us on time. One more.
Try to be quick. Mark, in that section, you talk about counseling people around substance use, drug use. Is there a place in the recommendations where you talk about evaluating people in terms of their ability to adhere based on active use of substances and or potentially not being stably housed or any of those other possible obstacles to successful treatment?
That's a very good point, and we didn't, as I said in my response to Sharon's comments, have a specific adherence section, but maybe we need to think about putting that in to incorporate that. I think there's enough data that antiretroviral success in supported IDU, for instance, if we're talking about substance use, does not show a lot of differences, but definitely we could look at an adherence section in there. So I thank you for that.
Good afternoon, everybody. I've been asked to present a section on recommendations for treating chronic hepatitis C in persons who are co-infected with HIV. So I'll go through our recommendations, and I have a small number of data slides in support of a couple of the recommendations. So the first recommendation is that all co-infected patients should undergo evaluation for hepatitis C therapy, class 1, level A. It does sound like a little bit of a motherhood and apple pie statement, but we felt it was appropriate to make it. And in support of that is, here's some data from a hepatitis C mono-infected population published in late December of 2012. And you can see that successful treatment of hepatitis C is associated with improved survival, all-cause survival, as you see on the left, and liver-related mortality on the right. And the important thing is that the comparisons on both graphs are people who were all treated for hepatitis C with, and this is before the era of triple therapy. And so these are patients who were deemed to be stable enough that you could actually treat them with therapy. And if treatment was successful, which is what SVR stands for, sustained virologic response, which is defined as HCV RNA negativity at least 24 weeks after completion of treatment, you can see those who achieve the SVR have improved survival. I do want to point out for this study, because I'll show you an HIV study in one more slide, that for this analysis, patients had advanced liver disease at entry. So you'll see that they had what we call F3 and F4 fibrosis. So Mark Hull referred to a Medivir scale. That's the most common of several liver fibrosis scales in use, where F0 represents no fibrosis or scar tissue at all in the liver, and F4 on the other end represents cirrhosis. So this is an analysis only of those who started treatment when their liver fibrosis was relatively advanced. Now, if we look at the next slide, this is from Spain, when they compared those who were treated, and it pertains to co-infected persons. So we see once again that in those patients who were treated with interferon-based therapy and achieved an SVR, they had improved all-cause mortality as well as improved liver-specific mortality. And the reason, and the p-values were significant in both graphs here, but the reason these curves don't diverge as much as they did in the mono-infected study I showed you is because this analysis is not restricted to people with advanced fibrosis at the time the treatment was initiated. So successful treatment of hepatitis C has rather important clinical outcomes. The next set of recommendations here are that in preparation for therapy for hepatitis C, evaluation of factors such as, and this gets back, I think, to one of the questions that Ron raised a short while ago about evaluation of factors such as substance abuse, mental health, housing, and food security. These are vital issues in contemplating hepatitis C therapy. So these are specifically mentioned in this section of the recommendations. And then also somewhat alluded to before is that looking after co-infected patients is generally most successful through multidisciplinary team approach to care. And then finally, detailed assessment for interferon-based treatment contraindications is essential. Now, this is alluded to in the text, and I'm not going to go through in great detail. When interferon was introduced some years ago, the list of contraindications was pretty long. I think over time we've come to learn that many of the conditions that were once considered contraindications are generally relative contraindications, and therapy can be cautiously initiated in the vast majority of patients, with the most obvious exception, pregnant women, for whom the therapy is absolutely contraindicated. But many of the other contraindications are relative contraindications, but it still is a process that has to be undertaken. So with respect to specific treatment for hepatitis C, our recommendations are based on therapies that are licensed now, not the many drugs that are in clinical development. And so Mark indicated that hepatitis C genotyping needs to be done because that influences treatment decisions. And so for those with hepatitis, there are 6 major genotypes worldwide. In Canada, almost everybody has 1, 2, and 3, with about 2/3 of the population having genotype 1 and say 10 to 15% genotype 2 and roughly 25% genotype 3. So for genotype 1, the recommendation is triple therapy with pegylated interferon, ribavirin, and either of the 2 currently licensed hepatitis C protease inhibitors, boceprevir or telaprevir. And we made this a class 1 level A recommendation. And consistent with the way these drugs are used in almost all studies and current labeling is telaprevir is given for the initial 12 weeks of therapy, and boceprevir is given after a 4-week lead-in of pegylated interferon plus ribavirin, and it's continued toward the end of therapy. And some data in support of that is in the mono-infected world of hepatitis C genotype 1, we have come a long way up to 2011 with having pegylated interferon plus ribavirin since about through 2003 approximately, with SVR or cure rates generally in the 40 to 50% range. And what was shown in 2011 in 2 independent trials is that in comparison to the dual therapy with peg-riba, the addition of the protease inhibitors, boceprevir or telaprevir, result in very substantially increased cure rates in genotype 1 infection, which led to the licensure of each of these 2 drugs in 2011, and the consequent various recommendations in the mono-infected guidelines around the world, including the Canadian guidelines. So the issue is, what do we know about co-infection? Well, there are small phase 2 trials that have been presented at scientific conferences with each of the protease inhibitors. Here's the one with boceprevir, where patients were randomized either to a control group of PEG interferon riba or a triple therapy group with PEG riba and boceprevir, and treated for 48 weeks. And what we see here is that the triple therapy group had a SVR or cure rate of 63% in comparison to only 27% in the peg-riba control group. And if you compare that to what was demonstrated with a similar regimen in a mono-infected population, it really is very, very similar. So if you give a hep C mono-infected population 4-week lead-in of peg-riba followed by 44 weeks of triple therapy, you have a 66% SVR. If you use a response-guided paradigm, which we do in the mono-infected patients, it's about the same at 63%. So what we see here from the boceprevir program is from the pilot data in HIV co-infected patients, we're really seeing just about the same SVR rates that we've seen in mono-infection, which is not the case what we saw with dual therapy. With dual therapy, we saw a reduced SVR. With triple, we're not seeing that. And similarly, what we see with a pilot study of telaprevir-based triple therapy in co-infected individuals, and it's again a pilot study with small numbers of individuals. If we just skip to the SVR data, we see once again that the triple therapy group did considerably better than those in the peg-riba dual therapy control. And if we again compare this to what we see in the Hep C genotype 1 monoinfected population, if we give them the same regimen with 12 weeks of telaprevir and a 48-week regimen of peg-riba, or if we compare on the right to the response-guided therapy paradigm, which is what we do in monoinfected, you see the results in the co-infected population virtually mirror what we see in the HCV genotype 1 mono-infected population. So that's the basis for the recommendation of the group that the co-infected population should be treated for the most part the same as we treat the mono-infected population, with the one caveat is that the pilot studies that have been presented so far did not use response-guided therapy in the co-infected population. They gave the full 48 weeks of pegylated interferon plus ribavirin. So we felt that we couldn't yet recommend response-guided therapy in a co-infected population. So that's what recommendation 24 is based on. At this time, we are recommending a 48-week background of peg-ribavirin with the protease inhibitor in the co-infected population. Now, response-guided therapy is currently under evaluation in other trials, but there is no basis to make the recommendation yet at this time. And we also recommended, I'm not going to show you the data set for that, that we use the standard stopping rules or futility rules that have already been established respectively for boceprevir and telaprevir. A small percentage of patients will be intrinsically not responsive to the regimens, and they can be identified by quantitating HCV RNA at specific points in treatment, and we are not recommending different rules for the co-infected population compared with what's already recommended in the HCV genotype 1 mono-infected population. Now, if with respect to retreatment, the draft guidelines that you saw didn't have the second word SVR in it. We then said there were no data on retreating people who failed peg-riba therapy who are co-infected. But what we can say now is there are no SVR data. But we don't believe there is a reason to think that they're going to respond differently. So we have a Class 2B Level C recommendation that even though there are no SVR data at this point, that on a case-by-case basis that retreatment can be considered. And since we had this recommendation for those who attended CROI or have seen some feedback from CROI, our colleagues from France in the ANRS have presented some on-therapy, not SVR data, in patients who failed peg-riba therapy who are co-infected with HIV, who've been treated with either boceprevir or telaprevir. They have presented data up to only 16 weeks on treatment in various treatment categories. And in this study, they chose to give a lead-in of peg-riba to both groups. And this is not a randomized comparative trial. I'm just showing you that there actually are some data that elsewhere in the world where clinicians, experienced clinicians, have chosen to retreat co-infected patients who failed a previous course of pegylated interferon plus ribavirin. So moving outside the most common genotype 1 into non-genotype 1. So for genotype 2s and 3 infected, co-infected individuals, we made a recommendation that is completely in agreement with the European recommendations and at variance with the US recommendations. And that is that we are recommending the dual therapy. Well, both guidelines recommend dual therapy with PEG and RIBA because the first generation protease, Hep C protease inhibitors are not particularly active against genotype 2 and 3. So in agreement with both the American and the European guidelines, we're recommending dual therapy with pegylated interferon and ribavirin. The subtle difference is we agree with the Europeans to recommend weight-based ribavirin as opposed to fixed-dose ribavirin in the genotype 2 and 3 populations. And we're also recommending that for those who achieve what is called in the Hep C world a rapid virologic response, which means HCV RNA negativity at week 4 of treatment, In patients who achieve that outcome, that a 24-week duration of treatment is sufficient, but if the RVR is not achieved, a 48-week regimen is recommended. And the basis for that is these are data from Hep C mono-infected individuals with genotype 2 and 3, and who were treated with PEG and RIBA for only 24 weeks. And if a person achieved an RVR, you can see 90% went on to get that SVR or cure. But if they failed to achieve an RVR, you can see that only 50 to 60% with 24 weeks of treatment will achieve the SVR that we're aiming for. So that's what we know from the mono-infected patients. We also know that in the mono-infected patients, if we treat for 24 weeks, the relapse rate is 10 to 16%. Relapse is defined as people who become HCV RNA negative at the end of treatment, but in that 24 weeks after, where you're waiting to see whether or not an SVR has been achieved, some patients will relapse. It's not from a new infection, as it was never completely cleared from the liver. And so we know that that's 10 to 16%. What we've seen in the co-infected population is that if they're treated with an 800 milligram fixed dose, which is what our American friends are recommending, although they're recommended for 48 weeks in everybody, you can see if you treat for 24 weeks, you have relapse rates between 30 and 40%. However, if you give the weight-based ribavirin to a co-infected population, the published relapse rates are actually very similar to what we see in a mono-infected population. So that's why we made the recommendation that if an RVR is achieved, 24 weeks ought to be sufficient. The alternative is to do what the Americans are recommending, treat everybody 48 weeks, which gives you very low relapse rates. The problem, of course, is it's twice the cost, and it's hard for patients to all get through 48 weeks. So that, I'm giving you the basis for the recommendations that we made. So I think that's the end of my slide set, but I'd be happy to entertain comments, questions, suggestions, and so on. I could do that. Let me see if Dr. Hall asked me to make a comment on belaprevir dosing twice a day versus 3 times a day, which I can do that if you would like. So, okay, I will. So
we know you're going to say it one way or another, so just go ahead.
I was only going to do it if asked. So belaprevir in the original registrational trials for mono-infected patients was dosed 3 times a day. There has been a phase 3 trial presented last year that was powered as a non-inferiority study with over 700 patients that showed giving the same daily dose split twice a day is non-inferior to giving it 3 times a day, and the company has filed for a label change for BID dosing. With respect to a co-infected population, although the pilot study that I showed you used TID dosing, there's an ongoing study right now that is in a co-infected population with belaprevir called the UNITE trial that is using a BID dosing. So I think in the clinic today, you know, some clinics dose it BID, some clinics dose it TID, and you know, that's really what's happening. And I mean, the guidelines at the moment are not directive on that point.
No, I think that the consensus was that we would remain silent since there is no data in co-infected populations.
That may be updated in the future when that result comes available, but for now the data.
Right. Yeah. Well, correct. I mean, the current data in co-infection is TID, just as we don't have current data in co-infection on response-guided therapy, but there will eventually be data, and you know, we'll find out how that turns out at some point. And I should point out that the response-guided therapy data in co-infection is restricted to treatment-naive and previous relapse patients. Nobody is studying response-guided therapy in previous non-responder populations. Are there other questions or comments before we move to the next section? Okay, thank you.
Yeah, nice job, Steve. Also, thank you very much to the audience. We were concerned that by this time the place would have cleared out. So really, it's really great to see how engaged people are. Thank you.
Okay, so I'm going to start off this section, then Pierre will follow. As we know, the directly acting antivirals, boceprevir and telaprevir, are substrates and inhibitors of cytochrome 3A4 and PGP. Telaprevir also has been shown to have some effects on renal transporters. Therefore, it's imperative that careful attention be paid to the risk for drug-drug interactions between these hepatitis C agents and antiretroviral therapies, as well as medications used for comorbid conditions in this population. With respect to interactions between antiretrovirals and hep C agents, recommendation 29, just a general comment that use of zidovudine, stavudine, and didanosine regimen should be avoided in co-infected patients being considered for hep C therapy. That's due to the additive risk of mitochondrial toxicity and anemia. Even though none of these agents are first-line antiretrovirals anymore, we felt it was still important to include this. Recommendation 30. So with respect to individuals with genotype 1 infection who are initiating therapy, it's recommended that use of raltegravir-based regimens for people considering either boceprevir or telaprevir or boosted atazanavir regimens for those on telaprevir can be considered as first-line antiretroviral options. The next recommendation is with regards to non-nuke treatment options. So in subjects with genotype 1 infection, the use of efavirenz can be considered in subjects on telaprevir. However, it should be noted that the telaprevir dose needs to be increased. This might not always be so acceptable logistically or financially for subjects. There are some data on, new data on ribavirin suggesting that it can be dosed safely with both boceprevir and telaprevir. And also etravirin-based regimens may be considered with telaprevir, but not boceprevir. So these last three recommendations, those are based primarily on the results of pharmacokinetic drug-drug interactions between these agents.
Any comments or feedback on those?
Yes. Yeah, there are data on both for ribavirin and both boceprevir and telaprevir. It can be used, so that should be updated a little bit. Okay.
I think I'm being told by Curtis that I have 30 seconds to talk about the next three recommendations.
You just used the first 10.
Essentially, to summarize a bit or to put in settings the next three recommendations, I think they highlights a number of issues we're having when it's time to talk about antivirals, drug-drug interactions with other medications. I guess the first one is the limited number of drug-drug interaction studies where we have to draw conclusions. On top of this, we don't necessarily know the nature and the directions of the drug interactions when it's time to guess based on the pharmacologic properties. We often have incomplete drug history when we see our patients, so just to highlight the fact that we have to do a best medication history in our patients, and also having a sort of a strategy for developing a monitoring plan for our patients, since that we have very few informations available. So the next slide, so the recommendation 32 says that assessment and monitoring of drug-drug interactions between boceprevir and telaprevir and commonly prescribed medications should occur at baseline and also at frequent intervals during HCV therapy. The recommendation number 33 is to ensure that medication records are up to date, as I just said. Use of a systematic approach to identify combinations of potential concerns, consulting pertinent HIV and/or HCV drug interaction resources, and frequent patient monitoring are recommended to try to minimize the risk of having these drug-drug interactions. Finally, the last recommendation is about the decision or not to continue medications that are not deemed necessary or vital for patients in light of not necessarily knowing what will be the drug interactions. So we state that the non-essential medications should be discontinued for the duration of HCV treatment, particularly when HCV protease inhibitors are used. Any questions or comments? Clarification we should be doing to these recommendations. Am I okay on time, Curtis? Yes? All right, thanks.
I am simply delighted that we're going to finish on time. So this brings us to the section on adverse events and management of treatment-related cytopenias. So we start off with a comment that both HIV antiretrovirals and current hepatitis C antivirals have multiple side effects. And then it was our opinion and thought that a comprehensive review of hepatitis C antiviral treatment side effects and management was really beyond the scope of guidelines. And we referenced a couple of reasonable reviews of the topic. We wanted to focus on sort of the key ones that are real headaches in managing our patients, and so that's why we focused on cytopenias. Okay. We did make an overall statement, however, that based on the phase 2 studies with boceprevir and telaprevir in co-infected populations, it would appear as though the side effect profile and the risk for adverse events and severe adverse events appears to be very similar to those with hepatitis C monoinfection. Okay. As we're likely all aware, managing anemia with triple therapy and genotype 1 is a significant problem in both hep C monoinfection and in HIV hep C co-infection. We discussed the rates are approximately 41% with boceprevir treated patients versus 26% in the interferon ribavirin controls. And we described the management options, which include ribavirin dose reduction, the use of erythropoietin, and transfusion. We acknowledge that this is based on hepatitis C monoinfection data, and that similar data are not currently available for HIV hep C co-infected individuals. We describe the issues with neutropenia. We reference several papers that suggest that despite significant neutropenia in monoinfection and in co-infected populations with interferon-based therapy, the risk of infectious complications does not seem to be excessive, and that is reflected in our guideline. So the first cytopenia comment is a close monitoring for side effects during hepatitis C therapy is required. That's obvious. With regards to anemia, anemia related to hepatitis C protease inhibitors should be primarily managed with ribavirin dose reduction. We know this from a key study evaluating, it was a randomized study looking at the use of erythropoietin versus ribavirin for the primary management of anemia in hep C monoinfected individuals, and it was demonstrated that ribavirin dose reduction did not have a negative impact on sustained virologic response rates and was as effective as erythropoietin. There is similar data with telaprevir as well. Okay. We also comment that erythropoietin use is not recommended for first-line anemia management. With regards to neutropenia, we state that developing neutropenia during hepatitis C is not associated with increased infection risk. Aggressive dose reductions of pegylated and or ribavirin or the use of GCSF is not recommended. Okay. And this is really consistent with hepatitis C monoinfection guidelines as well. Okay. Are there any comments about managing adverse events or side effects? Does anybody have any strong opinions that we should spend more time discussing this in the guidelines? Excellent. Okay. We finish with a short section on HIV and liver transplantation. Again, describing the issue that many of our patients are developing advanced liver disease that would require liver transplantation. We cover the criteria for which they'd be considered, which currently states a CD4 count over 200 and no history of recent opportunistic infections. Okay, and we describe some of the literature looking at the long-term, defined as 5-year long-term outcome for co-infected patients receiving a liver transplantation for hepatitis C, and 54% versus 71% in hep C monoinfected patients from a Spanish study. We also discuss hepatitis C management post-transplant, and we say and state that the use of direct-acting antivirals like the protease inhibitors is challenging because of drug-drug interactions with the anti-rejection medications. Okay. And that's about it for the transplantation section. We currently don't have an actual recommendation, okay, which I think probably merits some discussion. I think that the lack of a recommendation right now represents some of the uncertainty in the hepatology community about whether HIV hep C co-infected patients should be offered transplantation. Okay? You know, I have my own personal opinions on this, which is, yes, of course they should be. But when you do look at the literature, the outcomes at 5 years aren't quite as good as in hep C monoinfected populations. Okay? So you can mull over that, and if you have any opinions, please jot them down on your card. Okay? We then wrap up with a nice snappy conclusion, sort of summarizing the guidelines, references, and a bunch of tables and figures. Okay. That is the guidelines. I'll remind you that you can continue to provide feedback or review the document in great detail by going to this site. There was a couple of other issues I wanted to raise. One is with regards to current funding for hepatitis C treatment, not only in hep C HIV co-infected patients, but across the board. In previous hepatitis C monoinfection guidelines, there were actually a statement suggesting that there be a greater allowance for treating physicians to be able to use the durations of therapy that they desire. So specific examples include a 24-week limit on the use of interferon and ribavirin for genotype 2-3 infection, even if you have HIV, which, as Steve suggested, probably isn't ideal. Okay. Another potential issue is with the use of telaprevir in an individual on Systiva. Okay. And currently there is very little mechanism to get funding for a higher dose of telaprevir in that context. Do you think that we should have a statement, and we can work on the wording, sort of a call for greater access? Sharon?
in the right path.
Go, Kevin, go.
So first, I would like to congratulate you and your panel for putting together some very thoughtful and well worked out guidelines. I think we need an even bigger statement. You've got beautiful guidelines here, and me as a clinician and you as a patient, you come to me, okay, your guidelines say this is how I should be treated. I can't get that drug for that patient. That puts me in a very awkward position to not have it covered. So I think there needs to be some very strong data, statements that this is the data, we need to have access, we need to be able to individualize those decisions as per a patient's individual condition as to how long it is appropriate for them to be treated. And if we do this, we will avoid the need for transplantation.
Yep. Damn straight, sister. Okay, so yeah, good. Thank you for that. To the point of expanding what we're trying to accomplish, we will be coming out with an executive summary, so sort of a short, snappy recap, so that for those people who don't feel like reading 10,000 pages, can get the gist of this. And as I suggested at the beginning of this, we are already working with a number of groups, including Katie, for the knowledge translation and the advocacy piece of this. The field of hepatitis C treatment is changing dramatically. In 2 weeks' time, there'll be the European Association for the Study of the Liver meeting, and they'll be releasing 8 phase 3 final results with new molecules. So the panel is aware that in a couple of years, the treatment for hepatitis C is likely going to be dramatically different. With that in mind, we expect that we will be updating this much sooner than 14 years or so. I have been approached by some people who want to be involved with this, and so if there is an interest in contributing to this, please talk to Mark or me or Marina, and we'd be happy to include you in the group. As I said, currently this is an English document, but we will have a French one. It was suggested to me that perhaps there'd be a need for a Hebrew one. If you know how to write in Hebrew or any other language and want to write the guidelines in that language, then we'd be more than happy to facilitate that. Okay. Any other thoughts or comments from the panel? Good. So again, thank you very much to the people who have contributed to this, to the CAHR for sponsoring this symposium, and thank you very much for remaining here for the full hour and a half.